Good afternoon, everybody. I might just give it 1 or 2 more minutes just so people who are in the waiting room can join and then we'll get started. Okay, good afternoon, everybody, and welcome to the March CPD webinar hosted by the Discipline of Radiation Therapy at Trinity College Dublin. Just a gentle reminder that your mics and videos are disenabled and also the chat is unable to be used at this time. But if you have any questions, just drop them into the Q&A box that'll pop up in a few minutes and I'll put them to Claire at the end. So it's my great pleasure to welcome my friend and colleague, Dr. Claire Poole, to deliver this month's lecture. Claire is an assistant professor and the director of clinical education here in the discipline of radiation therapy in the School of Medicine at TCD. Claire is a very strong advocate for radiation therapy as a cancer treatment, with much of her research focusing on the barriers to optimizing or to optimal utilization of radiation therapy. She's also the founder and co-leader of the TCD Radiation Oncology PPI group, ACT at TCD. And their aim is to implement the voices and experience of patients, carers, family members, and the public into radiation therapy education, research, and service improvements. And today, I'm delighted to welcome Claire to share her insights from her research with her presentation. So, Claire, the floor is yours.
Thanks very much, Laura, for that lovely introduction. So thank you everyone for joining me today. So it's either good morning or good afternoon. So this webinar is titled Radiotherapy Effective and Available and Underused. And over the next 40 minutes, I'll walk you through what the literature tells us about this issue, but also where that understanding may be incomplete and why we need to broaden our focus. This work is based on findings from my PhD research alongside the existing literature and aims to bring those pieces of the puzzle together into a more complete picture of barriers to accessing radiotherapy. So I hope you find it as exciting as I do. So for me, this leads to what I describe as a clinical paradox. We have a treatment that is highly effective, evidence-based, and widely available, and yet it remains consistently underused. So we do know that 50 to 60% of all cancer cases require radiotherapy, and it contributes to 40% of all cancer cures. So this underusage is particularly puzzling in high-income countries, where resources are often not the issue. This gap or underusage still persists despite national cancer control programs, adequate infrastructure and resources, sufficient linear accelerator capacity. So the question is, why does this gap remain? Before we go any further, it's worth pausing for a moment to consider why this gap really matters. Because when we look at what it means in practice, the implications are significant. In Europe, for instance, only 1 in 4 eligible patients who require radiotherapy receives it when clinically indicated in the radical and palliative setting. If all eligible patients received radiotherapy, it is estimated that around 1 in 12 could experience a survival benefit. In addition, 1 in 3 patients could achieve 5-year local tumour control, which plays a substantial role in the long-term disease management. From a global perspective, Modelling studies suggest that closing the radiotherapy access gap could save up to 1 million lives each year. And importantly, this is not just about survival and radical treatment. Improving access to palliative radiotherapy has been shown to significantly enhance quality of life, particularly through better symptom control and pain relief for patients with advanced disease. To really understand this gap, this underusage, we first need to look at what the literature tells us. And when we do that, there are three broad categories: resource and system barriers, patient factors, and service level factors. So we'll just take a brief look at each one of these. I'll start with what the literature tells us about resource and system level barriers, as these are often the most commonly cited. Radiotherapy remains relatively underfunded globally, despite the fact that 50% or 60% of cancer patients will require radiotherapy. It accounts for only 5% of cancer care budgets and just over 0.5% of overall healthcare spending. And that level of underinvestment has real consequences. It contributes to limited infrastructure, workforce shortages, and constrained access to services. This literature also highlights the lack of value-based frameworks for radiotherapy. Without clear ways to define and measure value, innovations such as hypofractionation or stereotactic treatments can be slow to be adopted, or they are inconsistently implemented across systems. Alongside this, there are ongoing challenges in workforce planning, where insufficient long-term investments limit the ability of services to meet demand. So these are well-recognized barriers, and they are clearly important consequences to them. But the question is, are these the only factors shaping access to radiotherapy? If we move on from system level barriers, the literature also refers to these patient factors. One of the most prominent or well discussed within the literature is this financial burden, also referred to as financial toxicity. And this goes beyond the cost of treatment itself. It includes things like travel, accommodation, time away from work, and the wider impact on family or caregivers. Another important factor is age, as well as cultural or religious context. We know that older patients are less likely to be referred for radiotherapy. Sometimes that's due to comorbidities, but also due to the assumption about their ability to be able to tolerate treatment. At the same time, cultural beliefs, religious beliefs, levels of trust in healthcare, and preferences around treatment may also influence patients and how they engage with care. And finally, one of the most consistently reported barriers is fear and misconceptions around radiotherapy. Many patients have limited understanding of how it works, and concerns about side effects, safety, or long-term harm can influence decision-making. So while these patient factors are reported within the literature, they are never explored in any great detail, and their role in shaping access may be more significant than what we truly understand. Finally, the literature highlights a third group of barriers that are known as service level factors. Sorry, I see the image is quite poor. These service level factors include wait times, referral process, and travel burden. Delays in accessing radiotherapy, whether that's for consultation or for treatment, can influence both clinician decision-making and patients' willingness to proceed. In some cases, it's been reported longer waiting times may lead to alternative treatment options or even reduce treatment effectiveness. Another key factor is the referral process. which represents one of the most critical points in the pathway. The literature suggests that referral patterns can vary considerably, even where clinical guidelines are similar. This variation may reflect the differences in clinician preferences, their awareness, confidence in radiotherapy, which in turn can shape the treatment options presented to patients. However, it remains unclear to what extent these factors do influence radiotherapy access. And finally, travel burden. Radiotherapy are often centralized in big cancer centers, meaning that some patients must travel considerable distances for treatment. This can create additional financial, logistical, and emotional challenges and has been shown to influence both treatment uptake and decision making. Taken together, these service level factors highlight how the structure and organisation of care pathways can directly shape access to radiotherapy. So while the literature highlights a range of barriers, the focus has mainly been on those resources, infrastructure, and other possible barriers are highlighted, but they're not well explored. So we know, despite substantial resources, access to radiotherapy in high-income countries remains suboptimal, suggesting other systemic or patient-related factors at play. These barriers or factors are often examined in isolation, with limited understanding of how referral processes, decision-making, and patient experience shape access in practice. So what is missing is this whole system, stakeholder-informed understanding of radiotherapy access. So to address this gap, I developed a 4-part stakeholder investigation designed to explore radiotherapy access from multiple perspectives across the care pathway. Rather than focusing on a single group or a single factor, this approach brings together key stakeholders such as patients, their families, and health professionals, with the aim to build a more complete understanding of how access is shaped in practice. The first study we see here is a global survey exploring baseline knowledge of radiotherapy and the perceptions of barriers identified within the literature that I've just gone through. And that was sent to patients, their families, carers, and healthcare professionals. The second study used data mining within a large online community of learners who participated in a massive open online course, and this is referred to as a MOOC. The MOOC was designed to provide information about radiotherapy to patients, their families, and carers. This study aimed to explore perceptions of barriers to accessing radiotherapy and to assess these perceptions in more depth than the survey and consider the influence of educational engagement on these perceptions. The third study used stakeholder interviews to explore referral pathways as a potential barrier to accessing radiotherapy. It mapped real-world pathways, identified gaps within the system, and examined the factors that influence access, as well as potential strategies to improve it. The fourth and final study used a SWOT analysis and co-creation workshops to explore how patients and public involvement can address barriers to radiotherapy access, identifying priorities and developing patient-informed strategies with key stakeholders. Together, these studies move beyond isolated barriers to provide a whole system, stakeholder-informed understanding of radiotherapy access in the real-world setting. It's important just to clarify at this point, for my PhD thesis, high-income countries are defined as those with well-developed radiation oncology services. And to do this, I used the European Society for Radiotherapy and Oncology, which you probably all know as ESTRO, and it came from their project, Health Economics and Radiation Oncology, the HERO project. These countries have at least 7 linear accelerators per million people, indicating that access is generally not limited by equipment availability, and budget constraints are less likely to be the primary barrier to radiotherapy. So for the remainder of this talk, I'll focus on the key findings from my PhD research and how they both align with and add to the existing literature. And this is where our understanding begins to shift. Based on my findings, we may need to rethink the idea of a knowledge gap in radiotherapy access. Traditionally, the literature, as I've outlined, tells us that fear, misconceptions, low awareness are key patient-related barriers. Patients are often described as being afraid of radiotherapy, concerned about becoming radioactive, being burnt, or seeing it as a last resort. And the consensus has been that if we improve this knowledge within those patient groups, their concerns will be reduced and one of the barriers to access will improve. However, what I found in my PhD research challenges that narrative. Both stakeholders with high levels of knowledge, so the patient group, and those with very limited understanding of radiotherapy, showed a similar willingness to accept treatment when it was recommended. This suggests that at least within this cohort, fear was not an absolute barrier to access. Across all studies, a consistent finding emerged. Patients showed a very strong trust in specialist decision-making and a clear desire for survival that often outweighed concerns about treatment. And just for clarity here, when I'm talking about specialist recommendations, I'm referring to site-specific oncology specialists, such in surgery and medical oncology. So this strong trust and specialist recommendation suggests that the issue may not be a simple lack of patient knowledge, but how treatment decisions are framed and made within the system. We see this reflected in the role of the GP as well. While the literature often highlights gaps in GP knowledge, my findings suggest that in many high-income countries, GPs actually have a limited role in directly referring patients for radiotherapy. This highlights that knowledge alone is not the barrier. Access is shaped by how the system is structured. This suggests that patients are not necessarily resistant to radiotherapy due to fear. Rather, access is shaped by how and by whom treatment options are presented. Building on this idea of rethinking the knowledge gap, it's important to consider where decisions are actually made within the system. And that brings us to the referral pathway. If we look at how patients move through the system, access to radiotherapy is shaped within the pathway itself. Across the countries included in this research, which was Ireland, the Netherlands, Belgium, and Denmark, patients move from primary care, so the general practitioners, which is sometimes known as the family doctor, but primary care, to diagnostic and triage, to hospital-based specialists and into the multidisciplinary team before they reach radiation oncology or the radiation oncologist. What becomes clear is that decision-making sits primarily within this hospital-based specialists. They are the ones who determine which treatment options are presented. And crucially, the GPs do not have a direct referral route to radiation oncology. There is no way for them to get to here. So even if a GP recognizes that a patient may benefit from radiotherapy, they are not in a position to act on that knowledge. This creates a clear reliance on specialist-led decision-making, which ultimately shapes access. We also saw this reflected in our survey findings, where there was a strong reliance on medical advice. Many participants indicated that they would follow their doctor's recommendation. And that is important because the role of the healthcare professional in influencing decision making and treatment uptake becomes apparent. While the literature often suggests that GP knowledge may act as a barrier, my findings point in a different direction. So where does this leave the GP within this pathway? What emerges from the data is that the GP plays a central role, but largely supportive role. They are key in early triage, providing support such as psychological support and managing the practical aspects of care such as med certs, blood pressure, those type of administrative tasks. However, they are not positioned as decision makers in cancer treatment. Instead, they guide patients into the system where responsibility sits with the hospital-based specialists. So while GPs remain involved, their influence on whether radiotherapy is recommended or access is limited, not because of knowledge, but because of how the system is actually structured. It's important to say here, while GPs currently have a limited role in directly influencing treatment decisions for radical radiotherapy, there are points within the pathway, particularly within palliative care, where their involvement could be much more significant. And this is where the limitations of the current structure pathway begin to emerge. Because access to radiotherapy depends on specialist referral, which treatment options are presented to the patient is influenced not just by that pathway, but also how palliative care is understood within the system. Both the literature and my PhD research suggest that palliative care in general is often misunderstood, commonly associated with end-of-life care and medication-based symptom management. Within this framing, radiotherapy is not always recognized as a key palliative option, despite its effectiveness in symptom relief. So when patients could benefit, radiotherapy may simply not be presented. This creates a clear gap. GPs are well positioned to identify patients who could benefit from palliative radiotherapy, but they do not have a direct referral pathway, and their ability to act on that knowledge is limited. So there is potential for a greater role for the GP. Currently, it's constrained by both how palliative care is understood and also by how the system is structured. And ultimately, radiotherapy is not part of the conversation. It doesn't become part of the care. So when we take these pieces of the puzzle together, the structure of the referral pathway, the role of the GP, which is supportive but limited, and the way and we start to see a consistent pattern. Access to radiotherapy is not just about availability or understanding, or even whether it is understood. It depends on whether radiotherapy is considered and presented at the point of decision making. And that brings us to a critical question. What actually influences these decisions? Because if the specialist is the gatekeeper to access, then their perspective becomes critical. And this is where the role of the specialist really comes into focus. And what we begin to see is a clear contrast. And on one side, you have the barriers that are normally described. So the logistical barriers, the financial toxicity, the disruption to life, the burden of travel. And these are real and these are recognized by patients, but they are not ultimately what drives decisions. What really shapes the outcomes are two key factors: the drive for survival and the absolute trust in the specialist. And this is reflected clearly in what the patients told us. And this is just one of the quotes which I think encaptures that quite well. The participants stated, "I was dealing with the experts." They were referring to the specialists. They're experts. That's why we use their expertise. And together, these really place the specialist in a central position in shaping access to radiotherapy. And what this begins to show us is that not just who is making the decision, but how those decisions are actually made in practice. Across both the literature and in my own research, decision making in cancer care is often described as paternalistic rather than truly shared. Patients consistently reported that they felt supported, they were well cared for by their specialist, but when they were describing how they became to have radiotherapy or to have surgery, their role in the decision making itself was quite passive. There was a strong level of trust in the specialist recommendation and a willingness to proceed with the treatment recommended, particularly when it's framed in the terms of survival. Using this model, it assumes that patients are being presented with all the viable options. And what I found is that this is not always the case. Patients often described being given a single recommended option rather than a balanced discussion of alternatives, including radiotherapy. So while patients valued clear communication and wanted to feel heard, their role was often limited to accepting or occasionally questioning the recommendation provided. And this highlights the critical gap, in my opinion. Even among well-informed patients, decisions are largely shaped by what is presented to them. If radiotherapy is not introduced as an option, it's unlikely to be considered. And as a result, the specialist's recommendation, so that's the medical and surgical oncology in particular, becomes the dominant influence on radiotherapy access. So this brings us to the next question. Who and what determines which options are presented in the first place? Because if the specialist is shaping what enters that conversation, then their perspective on radiotherapy becomes critical. And this is where we begin to see the influence of what is described in the literature as referrer bias and is also reflected in my PhD research. So if access depends on what is presented, the next question is why some options are consistently prioritized over others. And this is where the concept of referrer bias becomes important. What I found in my PhD finding closely aligns with the literature. Treatment discussions were often framed around surgery or systemic therapies, with radiotherapy less frequently presented as a primary option. In many cases, it's appeared to be positioned as a second-line treatment, unless clearly embedded within the guidelines for that site. And this is where referrer bias begins to take shape. As decisions are shaped by the specialist perspective, specialists, quite understandably, tend to recommend their own area of expertise. It is this referrer bias that influences the treatment pathways. And what's important about this is that this is not a lack of knowledge. Radiotherapy is well recognized as a treatment option. What this reflects is something a lot more nuanced. A gap in awareness and confidence around radiotherapy as an effective treatment is often not there. Excuse me. Clinicians know radiotherapy exists, but they do not necessarily have confidence in it or are aware of its effectiveness within the treatment pathway. And alongside this is a broader issue, the limited visibility and less clearly defined identity of radiation oncology within the medical field. So moving on from referrer bias, we move to a more subtle barrier, and this is the visibility and the professional identity of radiation oncology itself. When we talk about barriers to access, we often focus on that infrastructure or resources, but what emerged across all my studies is something less tangible, how visible radiation oncology actually is within the wider system. Across all 4 studies, a consistent pattern was clear. Radiation oncology is not always clearly recognised or understood. not just by the public, but even within the medical community. It does not have a cohesive professional identity. In fact, one of the most striking insights, particularly from the GPs, was that radiation oncologists were sometimes described as the anonymous doctors. Part of this stems from the profession itself. Radiation oncology does not have a single cohesive identity. It is referred to in different ways. So we talk about radiation oncology medicine. When we're talking about the doctors, they're referred to as radiation oncologists, clinical oncologists, radiotherapists. And then when we are talking about giving the treatment, we talk about radiotherapy or giving radiation therapy. So what we're seeing is a very fragmented professional identity, and that has important implications. Because in a system where visibility matters, if a speciality is less visible, it is less likely to be considered, discussed, or prioritized within treatment decisions. And this is something that's not always fully captured within the literature. There is very little attention on how professional dynamics and visibility has an impact on decision making. There is often limited awareness in the medical community when and how to involve radiotherapy in the care pathways. So when we bring this together, it suggests that radiotherapy is not just about availability, it's also about its visibility, its identity, and its presence within in the cancer care pathway. Extending this further, the next question is, what does this look like within the MDT? And there's a reference to these unconscious hierarchies. As the multidisciplinary team is the setting where treatment decisions are ultimately made. What both the literature and my PhD research suggest is that radiation oncology may be underrepresented in this context, particularly when compared to medical and surgical oncology. Surgeon and medical oncologists are often reported as leading or chairing these discussions, these specialist-led discussions, while the role of the radiation oncologist is present, is less clearly defined within the literature. What also emerged from this research is that radiation oncologists talked about within their interviews often having to, excuse me, actively advocate for radiotherapy to ensure to ensure it's considered as a treatment option. Sorry, getting a dry throat. In larger cancer centres, this advocacy can be strong, but in smaller settings where subspecialisation may be limited, that influence can be reduced. And this has important implications because if radiotherapy is not strongly represented within the MDT discussions, it is less likely to be prioritised or fully considered. And what we begin to see is a pattern where the treatment decisions can reflect the perspective of the dominant speciality rather than a fully balanced discussion of all the options. So when we take these findings together, so this is the summary of the new findings from my own research, what becomes clear is that the challenges we've identified are not primarily about resources, infrastructure, or patient fears and misconceptions, even though they are all present. What is important is how decisions are made within the system. And this is important because it suggests we may need to change our focus a little. If access is shaped by that specialist influence, referral pathways, and how treatment options are presented, then improving access requires us to address those points directly. So the question then becomes, what needs to change? And this is where I've just chosen three key ones, areas for action. Firstly, we need to shift our focus towards these gatekeepers of access. the specialists, who play a central role in determining which treatment options are considered and presented. We can shift the focus from patient awareness to professional decision making, address professional knowledge gaps regarding radiotherapy efficacy in particular among the referring physicians. What we need to address is not whether the specialists know about radiotherapy, because a lot of the time they do, but how well they understand its effectiveness. Are they aware of the advancement in technology and when it should be used? This requires a much stronger interdisciplinary education where radiotherapy is not seen as an adjunct but as an equally effective treatment option in the right context. And ultimately, it's about improving the visibility and confidence in radiotherapy within multidisciplinary decision making. We also need to consider the healthcare model that's there at present and shift from a hospital-centric model to a system-wide referral approach that allows referrals beyond the hospital setting to improve access. We need to strengthen the visibility of radiation oncology and ensure equal multidisciplinary team representation in decision making. In Belgium, for example, the multidisciplinary teams are incentivized to include radiation oncologists through reimbursement. And there is a strong advocacy within the literature to finance MDTs effectively. And finally, the last key change we should make is mandate inclusion of the patient voice. Move the patients from these passive subjects to active partners. Integrate patient voices directly into the radiation oncology's policies and strategies. So what we want to do is move from this paternalist. So we want to embed PPI in shared decision making. And we want to move from this paternalistic decision modeling to shared decision making. Not one size fits all communication. You tailor the communication and you have it inclusive. And we need to create this bridge so we actually do give personalized care. And what's important about this is that we need to move beyond this tokenism of PPI in radiation oncology. It cannot be limited to the end of process surveys. It requires active patient partnerships through research, education, and clinical design. What is central to this at the level of care delivery is the concept of shared decision making. We need to move away from the illusion of the choice to actual collaborative treatment selection based on patient values. And this needs to be included in the postgraduate and undergraduate medical education. And alongside this is inclusive communication, ensuring that information is clear, tailored, appropriately paced, and truly understood so that patients can meaningfully engage in decisions about their care. This also extends beyond the clinical setting. Before I conclude, it's important to acknowledge some of the limitations of my research. And I suppose one of the key ones is this study focused on a European context. And most participants within this study were very well educated. They were from high income settings. There was limited cultural and demographic diversity. However, despite this, the challenges that were identified, such as limited confidence in radiotherapy among referring clinicians, unclear referral pathways for accessing palliative radiotherapy, and the relatively weak professional identity of radiation oncology, are unlikely to be unique just in this context. Instead, they likely reflect broader patterns across many healthcare systems. So while the findings are grounded in a European setting, the implications may be widely relevant. And overall, what this work suggests is that improving access to radiotherapy does require a shift in focus from availability and patient awareness to decision-making, professional influence, and the system design itself within national cancer control programs. because access to radiotherapy is not just defined by availability. It has to be considered, presented, and prioritized. Um, and if it's not accessed. I quickly would just like to thank all those that helped me in my PhD. The list is long, so I'll just flash it up there. And also to highlight what I've moved on to next. And I suppose it's clear within my PhD research that I didn't actually interview medical or surgical oncologists, and that is what I'm moving on to next. So if anyone's online that knows medical and surgical oncologists that are willing to give up some time for an interview, please do send them my way because it is important to get their perspective. And also, I'm working on embedding PPI nationally into radiation oncology in Ireland. And of course, I'm not doing this alone. That is from my clinical partners in Ireland itself, across Ireland, and also those working with me within the discipline of radiation therapy, who are also too many to name in this webinar. But thank you, everyone, for helping me with this initiative, which I think is very important. And thank you all for listening for me today. And as this is being recorded, you will see that I have all my references here at the end. So I'll go back to thank you. Thanks very much. Sorry
Great.
for all the coughing.
Great, Claire. Well done. That was really excellent. And just a reminder, if anyone has any questions, just pop them into the chat box and we can work our way through them. That was great, Claire. It's well, to start with, I guess, because we're in radiation therapy, I was quite naive to see just how underutilized it is. I mean, I was shocked to see those stats at the very start. Um, and I think so. You kind of then went on to highlight the that no longer are patients afraid of radiation therapy, which is kind of good to hear as well.
Well,
That
it's not really that they're not afraid. It is that there are fears and misconceptions. But I
okay.
suppose so. But there's probably fears and misconceptions about all the treatments. But what becomes clear is that if you have so what the patients would have described, though, is if they have a consultant in front of them that is confident in the treatment that they're given, describes that treatment and offers it, they will go with that decision. So they will overcome their fear to have that treatment. So it's not that they don't have any fear or misconceptions, they are present, but the decision making is more influenced by what that expert or that specialist recommends. And so why that's important then is if they don't see radiotherapy as the an equal option, but you have it afterwards or you needed to mop it up, well then they're more inclined to go for surgery or systemic therapies first.
Yeah, and I guess kind of sticking with the patient perspective, you kind of referred to sometimes there may be kind of cultural beliefs and religious beliefs that impact on their decision making as well at the very outset. Did you find anything like that in your research findings?
No, so in my particular, and that is one of the key limitations, there is limited cultural diversity within this cohort. So it would be something that it could be specifically looked at. But I suppose and they are important factors because that can vary between jurisdictions. However, I suppose what's important here is that within a group of highly educated, well-informed patients, they were still influenced by
Mm.
what that expert or that specialist recommends. Because when you become a patient, um, and what the patients discussed a lot is you're in this survival mode, and it can be difficult to make decisions. And that's why shared decision making and involving the patient as a partner is so important, because they're doing this under wanting to be treated and cured from their cancer.
And then I guess, so just kind of saying with in terms of the shared decision making, so even for those patients, say that are very well educated, kind of understand their disease and understand their treatment options, even still, even at that level, that shared decision making is really difficult to achieve.
Yeah, because a lot of the
Yeah.
time, even though patients talk about that they want really clear communication. They want to be informed. However, when they're describing how they were recommended to radiotherapy, and it's particularly in sites where the guidelines are not clear,
Mm.
um, they they um, they don't really question the clinicians because the
Okay.
clinician will tell them why this is a good treatment to have, you know what what the stats are for it, and they just take their word because they're the experts. They know what they're doing. They've years of experience, and what would I know to question them? But if you use shared decision making, you find out from the patient, well, what is important. And the other important factor is a lot of the time when they're getting offered those treatments, radiotherapy is not offered to them. So they're not given dual. So there is an example within Denmark of dual consultations for head and neck cancer patients where radiotherapy and surgery meet the patient at the same time, and
Wow.
that's where they do um, find out what's important to the patient, and then they decide the treatment based on that, rather than I think it's best or you think it's best, if that makes
That's
sense.
fascinating. That sounds like a really based on your findings, a really excellent approach to take. If
Yeah.
it's the first person they meet is the person that helps them make the decision, and if they meet two people at the same time, then it's a much more collaborative, shared, inclusive patient kind of decision. Anyway, sorry, all my questions here. I better jump into some that have come. So really excellent presentation. Do you think we need to look at different approaches in different healthcare settings to tackle underutilization, for example, public and private?
Sorry, I don't understand what's the question?
So, do we need to look at different approaches in different healthcare settings? So, would the approach be different if it was in a public setting versus a private setting, or are there more generalized approaches that can be taken across both?
Well, I think one generalized approach, whether you're in private or public, is really in the postgraduate setting. So I have begun some of those interviews in for surgery and medical oncology. And what you find is there's no real education around radiotherapy. They kind of learn on the go. They learn on the job. I presume, and I'm not familiar enough with the private settings, that all patients go through multidisciplinary teams. Sometimes the problem can be in smaller departments. The radiation oncology may not, the oncologists themselves may not be specialists. So I think there probably are specific things for specific hospitals, but I think in general, first, what we need to really make clear to other professions is what is radiation oncology, and it's not that old treatment. We are now very personalized, very advanced. And when you look at the education, now I only looked at it in relation to what was available online, but you will see when in surgical oncology and medical oncology, when they're educating the professions around radiation oncology, it's really this is radiation oncology, this is what it does, this is what it, rather than we need to think about how we teach it. And I think we need to focus more on how effective it is, how personalized it is, how, you have stereotactic hypofractionation. And I think there is misunderstandings or that's that type of improvements that we've made in the last 20 years is not known, and a lot of the time um they learn on the go. Sorry, I'm not sure if I answered that question, but I think
No,
it's not really, I don't think it's specific. I think it's more the education and the focus um is the first thing. um
as opposed to the actual setting where it's
yeah,
delivered.
yeah,
Yeah.
yeah.
Sorry, another question here. Again, excellent presentation. Thank you. Is radiation therapy utilization rates higher in places like the UK, where the clinical oncologist is the medical radiation oncologist, compared to countries where we just have radiation oncology specialties alone?
It's a very good question.
Hmm.
As far as I know, no, that doesn't
Okay.
that doesn't necessarily, because even if you're a clinical oncologist, you're still coming in through medical oncology. So in the UK, for example, they would have, to my knowledge now, someone can correct me on this if they're online, but they still have medical oncology. So it's where you're referred into is the important factor, and where you're referred into usually is the, and then you go to clinical oncology, or there you go to radiation oncology. And as far as I know, in the UK, for example, there's still now resources also an issue there at the moment, but there is high under usage of radiotherapy there as well. So I don't think the fact that you're a clinical oncologist necessarily, and there would be some debate, and I know they're working on this in the UK now, that actually with clinical oncology that they're more medically focused or trained sometimes than radiotherapy specific. So, but they are bringing in the UK now this dual STEM, where that when you're doing medical oncology or radiation or clinical oncology, medical oncology, that they have this STEM where they learn about both. So because there's a criticism of clinical oncology focusing too much on the systemic therapies and not enough on the radiotherapy.
Okay.
Yeah.
And then I guess so you laid out quite nicely where the path to the future is and maybe where improvements can be made. And I'm just interested, that was a really interesting example that you find in the Dutch setting where the two oncologists, the medical oncologist, was it medical, sorry, or surgery and the radiation oncologist sit together. Are there any other examples, Claire, that you think could be useful to use more widespread in kind of counteracting this single specialty recommending their own profession and or their own treatment modality rather than looking at the whole gamut that's available and maybe suitable for patients.
Um, I mean, I do, there is evidence to show, I kind of mentioned it there, that
Yeah.
incentivizing radiation oncologists to actually be at multidisciplinary meetings, and that's done in the Belgium setting, that apparently works
Okay.
quite well. I think, sorry, what was the question? It was what
Uh,
strategies was it?
yeah,
Sorry,
was there any
forgot
other
those.
in your research, do you find any other useful strategies that kind of maybe you kind of call, oh, that's a great idea. Could we look at maybe implementing something like that to counteract some of these barriers?
No, I think the real one was the meeting together
Mhm.
to work in the first place. And what you do see in some is in palliative radiotherapy is community being able to refer
Mm.
um, directly into radiation oncology. What currently happens is the moment as you go back to your original referrer. So somebody that finishes radiation oncology might go back to the surgeon or the medical oncologist to refer them. So something within the community, because if you go back into, there are cases, if you go back into medical oncology, for example, that they're more inclined in a palliative setting to give more medication maybe than actually referring for radiotherapy. So I did read some examples of where that pathway was changed so people could direct referral in, and that worked well. But there are only kind of pockets here and there. There's no consistency, and I do think we'll need, if to get radiotherapy used more in the palliative setting, we need to look at the way those patients are referred, because that could, I think, be done much better. And again, that does come down to knowledge then of what the indications are.
Great. I might go for another question. Again, great. Thanks for an excellent presentation. In relation to patient factors, did age come up as a factor for patients accessing radiation therapy?
So, I suppose I didn't look at age specifically in this study. And the reason I didn't is because there's a lot of research about age. My colleague, Dr. Anita Donovan, researches extensively in that. So it is a factor, but I didn't specifically look at it. I looked at other factors instead. There is evidence that patients are judged by what age they are. So they're this biological age rather than how fit they actually are. But I didn't look at it specifically. It is a very
Um,
complex, there's lots of factors. Yeah.
and again, this kind of question touches on maybe what I had asked. So again, really interesting presentation. Would you have any policy recommendations from this work?
Yeah, return. Look at the national, the referral and the way referrals are done. We're very hospital centric. There needs to be other ways to get into radiation oncology. They were often referred to as the anonymous doctors, the GP. So from my research, a lot of people talk about, and of course it's different, a little bit different in different jurisdictions, but there is no real route for a GP to actually refer a patient in. And a lot of the time, they may not need to go, but I think we need to look at the referral pathways. And I also think policy around education, particularly medical education. I think the one of the medics, radiation clinical oncologists I spoke with, they only get 14 days of education on radiation oncology. So we need to look at the education in the undergraduate medical curriculum and also in the postgraduate. Um, so they would be two key policies I think that need to be looked at.
Great. There are a few more questions there, but Claire, maybe in the interest of time, we might look at wrapping it up, and I can put them to you later over coffee.
And
But
anyone can
this
email me if they wish at poolc at TCD. Happy to hear from you. Okay.
great. And as Claire said, this webinar is recorded and it'll be available on our discipline of radiation therapy at TCD website in the coming days, along with all the presentations we've had in the previous few years. Thank you, Claire. That was a really compelling and kind of thought-provoking session, certainly for me, and I'm sure the audience there. There was lots of positive questions and comments as well. I guess it reinforces how important collaboration is between healthcare professionals. At its essence, I think that's kind of maybe where a lot of our improvements can be made. And ultimately to ensure patients get access to radiation to start with, and then they can get the benefits from it after that. If they can't access it, they can't acquire the benefits, and particularly I think in the palliative setting as well, it's really important. So thank you very much, Claire. Thank you everybody for joining us, and I'll be putting out the notice for the next webinar. The April webinar is coming up shortly, so watch this space. Okay, thank you
Thank you very
everybody.
much. Bye.